Welcome to Workforce Central, the official podcast of the National Association of Workforce Boards. Stay tuned as we explore the latest resources, thoughts, and trends in workforce development. And now, here's your host, Ron Painter.
Welcome to another edition of Workforce Central, a podcast from the National Association of Workforce Boards in Washington, D.C. Doug Foresta is at the controls. I'm Ron Painter, your host. Today is a really interesting conversation for me because it kind of combines a couple of things. Certainly interest in early childhood and interest in occupations, and also a conversation with a most interesting foundation. My guest today is Dr. Alice Werner, and she is the Director of Policy at the WK Kellogg Foundation in Battle Creek, Michigan. Alice, welcome and thanks for joining me.
Thank you for inviting us.
Alice is responsible for formulating, recommending, and consulting on policy strategies, objectives, and plans on behalf of vulnerable children and families. She's a key partner in the staff operations at Kellogg, where she has served as a program director in policy, health, a program officer in family economic security, and a lot of what we want to talk about today, place-based work, initially with the New Mexico team. Alice holds a bachelor's degree in psychology and a master's degree in communication from the University of Cincinnati in Ohio, a great workforce partner, by the way. She also earned a master's degree in health and hospital administration from Xavier University, and also her doctorate is in human and organizational systems from Fielding Graduate University in Santa Barbara, California. So again, Alice, welcome and thanks for joining me.
Thank you.
For those of folks who are listening, may not be that familiar, tell us a little bit about the WK Kellogg Foundation.
Mr. Kellogg of the Kellogg cereal fame was a man who very much wanted to invest his money in people. And particularly, he said, do what you will with the money, but invest it in the health, well-being, and happiness of children. People ask us, well, you don't know anything about dentistry, you don't know anything about oral health, and the kids do have teeth. And one of the things that Mr. Kellogg spelled this out in 1930 in his children's charter. And for those of you that are like wonky and want to look, we do have our first 11 years document that's available online, I believe. But he talks about some very core values. And oral health actually falls into that set of the things that are necessary for a child to develop well, to have the opportunity to thrive, and to live long and healthy and productive lives. So he really looked at that trajectory. And so all of those key elements actually appear in this work that we're doing in oral health. But I want to tell you, in 1930, the oral health part of that was done as dentistry. So the Kellogg Foundation has funded actually the workforce side of that to provide better access and high quality care to people in communities. And so that community element and the communities, Mr. Kellogg always said, communities, they understand their problems and their challenges, and they need a little bit of resources to be able to help solve that problem. And so with dentists and with doctors, there was funding for scholarships. There were funding in the 50s for the hygiene development of the dental hygiene field and associate degree nurses. And then back on the oral health track in the 70s, the extended function dental assistants. All of those were pieces that really speak to Mr. Kellogg's values around children, the community, and the engaged community in the health and well-being of our children, and the fact that all of us, it takes all of us for them to thrive in wherever they are.
Key to Kellogg is the notion of optimal child development. Was it that combination with Mr. Kellogg that led you to take a really place-based focused? I mean, lately there's been a lot of conversation in economic development and in our world about place-based, the importance of place-based. How important is it? What is it? But that's a legacy for Kellogg, is it not?
Mm-hmm. And it shapes your identity. It shapes your opportunity space. It shapes all of the systems that interface with you as you grow up. For a child, all of us grow up in communities, whether they're rural, whether they're metro, whether they're suburban, whether they're urban. It's about the community and the relationships of all of us in communities. So the place is essentially, in the relationships in the communities. And I want to, if it's okay with you, I'd like to kind of move to the Alaska project, because Alaska is not one of the places most foundations consider like a first go-to. This particular proposal came to us over the transom. It was not solicited. And yet, it really spoke to a problem and communities, the Native communities, Alaska Native communities, have identified as a long-standing problem where their children and the people in their communities did not have access or did not receive any oral health care. And that would be for periods of years, or, there would be a dentist that would visit, and mostly for the purpose of pulling teeth. So you would find children at the time that they came in. I think Mary Willard, who I think you'll talk to in a future podcast, said that 90% of the 2-year-olds were in the OR having their primary teeth removed due to caries disease and decay. And then at 18, many of the children had a full set of dentures, and most of the elders and many of the elders were edentulous. And that means they didn't have any teeth remaining. That was an expectation because there was no care.
What attracted you to what they thought was the solution?
They looked at other indigenous communities that had this problem, and they landed on a model from New Zealand. For the past 100 years, dental therapists have been providing services many times in indigenous communities or in rural communities, but largely for children. And they sent 6 of their community members to New Zealand for training. And they came to us and asked for support for implementing the dental health aid therapist, is what they're called in Alaska. They are a mid-level provider, to go to New Zealand and come back and practice in the Alaska Native villages. So, for us, we looked at this, and the access was going to improve, the health outcomes of the children would improve, the workforce, there would be jobs that would be provided. The organized profession felt that this was second-tier care, that the dental therapists should not be allowed to practice. There was a lawsuit initiated by the Alaska Dental Society, and it's actually worthy of looking at. Attorney General stepped in, there was a settlement, and the dental therapists were able to begin work. And so now there's between 40 and 45,000 Alaska Native people and kids in villages that are receiving this kind of care. The health outcomes are improving. They are looking at that for every dollar that the DHATs bring in, it costs 30 cents to provide that care for a DHAT. They only do 46 of the 500 procedures. They're what we call basic and routine. They do them well. And so we supported that program, and we supported it for all of those reasons. And they work in teledentistry up there. They are checked for all of their procedures by dentists supervising them. They do a 400-hour preceptorship under the direct supervision of a dentist, and they are not allowed to practice procedures until the supervisory dentist approves their practice of that procedure. So they might only be able to do 42 until they can prove proficiency in all 46. It's high quality. We've done evaluations. Other people have done evaluations. very efficient. It hits the triple aim of population health, cost efficiency, and high quality care that patients are satisfied with. And in Alaska and in other places where they're starting to do this, what you're finding is beyond cultural competency, it is culturally responsive and entire expectations around, having teeth and having the community change their ideas about nutrition and having, pop and vending machines in schools or all of those kinds of things. So it's a win all the way around.
What the new federal legislation puts on the board is this role of convening, is this role of looking at workforce development as a system. A lot of debate about where do new occupations fit in and what's the mix, what's our focus. So your thoughts, and I want to come back and also ask you about, what does Kellogg learn from all of this engagement in place-based? But let me afford you the opportunity to talk about the role of workforce boards.
The thing why we wanted to talk to workforce boards is that the oral health and oral health professions rarely come into their purview. Many times, if you ask a community what the most pressing need in terms of health or in their community, it's going to be about oral health. And that showed in the Surgeon General's report. It showed up, actually we're in worse shape now than when the Surgeon General issued about the only report on oral health that's been done from that national office. And we are in worse shape now than we were in 2000 when that report came out. So, for workforce boards, we think it's not only a critical need for the community, and in every single place, whether it was Maine, Minnesota, the 5 states we're working with, New Mexico, Washington State, Ohio, Vermont, and Kansas, all of these are community people that are saying, we need this, we want this. And those workforce boards actually are the same people in the community. And so we're saying, here's a route to address a pressing community need, something that the people in the community have engaged in and brought their voice to. In Oregon State, we have some pilot demonstrations that are done under enabling legislation that was passed that allows demonstrations of alternative oral health professions that can address the access needs and the pent-up demand. Oregon says, it's going to go through this very rigorous process for application, but there are 3 tribes at this point, Native American tribes, that have one of these demonstrations going. And I guess it's 2 in Oregon and 1 in Washington State. In Minnesota and Maine and other places that have passed this, there's been a requirement that 51% in Minnesota, for example, need to be Medicaid, that Medicaid patients that need to be part of the patient mix. And it's very interesting because, even in these, or they have to be in a rural setting, places that are not generally served. Standardly, I know that Frank Catalanato has information on dentists and dental providers in Florida, and if he looked at that, it's a very, very small number. Even take 1 Medicaid patient per year. So there are a lot of that unmet need is from uninsured Medicaid and those that generally are served under the Affordable Care Act. The standalone dental plans that kids are supposed to have are out of the economic reach for a lot of people. So Indian Health Service is looking into expanding the CHAP program, which holds the DHAP program for tribes in the lower 48. But there are a number of states where the communities are continuing to put pressure on their legislatures to allow this kind of provider to practice. And they're coming to us for support, and that's a part of what we see the mission to be.
So, Alice, let me ask this question and then ask for your closing thoughts. So, Kellogg's approach that is community or place-based focus. When you sit back and reflect on what you've learned about, I guess, for lack of a better way to say it, what works when you step back from a community? What are some of those ingredients that you think work in communities that are economically viable and provide good work or for the people who live there? What are some of the ingredients that make a community prosper, sustainable?
I think for the most part, and again, even looking at this body of work, but all of our bodies of work, it is the strength and inclusion of all the members of the community in that work. And in terms of this work, in closing parts that you are asking about, one of the big frames for this is racial equity. And, right now, the oral health profession is probably one of the widest professions. And so we say, how do we get a diverse pipeline? How can we bring people from the community and bring them back to the community to serve in the community? And, in Alaska, what they say is we come from the community, we're staying in the community, and we're serving our family, our friends, our neighbors, and the ones we love.
Well, thank you. Dr. Alice Werner, Director of Policy at the WK Kellogg Foundation. Thank you very much for joining me, and I hope we can come back and talk more about the Kellogg Foundation's involvement, community civic engagement. I know you mentioned racial equity, which is part of your, I guess, the pillars of the philosophy of the Kellogg Foundation. So, Alice, thanks for joining me today.
Thank you so much. It was a wonderful conversation.
You've been listening to Workforce Central, the official podcast of the National Association of Workforce Boards from Washington, D.C. I'm your host, Ron Painter. I hope that you will join us again as we continue to talk about workforce development and the issues in our industry. Thank you.